Fantastic. So we're going to give everybody that has not yet joined one more minute to the audience that has joined, and then we're going to begin. But thank you all for coming today. I hope you can see that right now. You're seeing a screen that shows who has sponsored this event today. It's Taste of Science Houston, the Association for Women in Science, the Association for the Society of Microbiologists, who do a wonderful program working with local high schools and doing outreach, and really support you guys supporting them. Okay, with that, let's begin. As a special project collaboration between the American Society of Microbiologists and Taste of Science, we welcome you to COVID-19 Part 2, The Path Forward. It's been 5 months since the first cases appeared in China. 1 month later, we would have cases in Europe, the US, and the rest of East Asia. As of today, we have 3.5 million cases worldwide, nearly 250,000 deaths, and thankfully, 1 million recoveries. In the past months, we've seen historical measures taken to limit the spread. We wear masks, we stand 6 feet apart from each other, and suddenly the alcohol in our hands is worth more than the one in our cups. Some say we're at a so-called flattening of the curve, and we're starting to see governments open up the economy with restrictions. But there are the counter voices that say it's just too soon, and we're not yet ready to face a second wave of infections. In yesterday's session, we discussed the myths and the misinformation surrounding COVID-19. Today, we're going to look forward. We have a panelist of specialists that are ready to discuss the tests, the treatments, and the general path forward. Our webinar today will consist of a speaker introduction and their specialties, followed by a roundtable discussion guided by the questions you submitted. But don't worry, if you didn't submit a question, our last section will be a live question and answer. So go ahead, pose your questions in your Facebook, Zoom, or YouTube feed, and our team in the background will pass them up to the specialists. Now, if you see a question that you think needs to be asked, give it a like, tell us you want it answered, and we'll make sure that it gets prioritization and gets to the specialists right away. You may also see that your questions are getting answered in a live feed. That's because we have a team of PhDs working in the background who are answering your questions if they can. This ensures that everybody's question gets the best chance to be answered. Okay, I think that covers it. So let's go to Bailey for our speaker introduction.
All right, thank you so much, Amir. Hi everyone, my name is Bailey Kane and I'm a PhD student at BCM and actually also an ASM officer for the Texas Medical Center chapter of ASM. Thank you so much to those of you that joined in yesterday, submitted questions, and engaged in our discussion about debunking popular COVID-19 myths. To anyone that's joining us for the first time, welcome and thank you so much for joining. I have the pleasure again of introducing our amazing experts for segment 2. So let's get started. And when I say your name, could you please wave to the audience so they can know who you are? So first, Dr. Aisha Khan. Dr. Aisha Khan is a clinical microbiologist and infectious disease scientist at UT Health, dedicated to reducing the global spread of antibiotic-resistant superbugs by creating innovative diagnostic tools. She serves as the Texas ambassador to the American Society for Microbiology, or ASM, and as the president of the Texas Medical Center chapter of ASM. Dr. Khan is working on the ground to develop and run COVID-19 diagnostic tests. Our next expert is Jill Losh. Dr. Jill Losh is a program project manager who helps research labs with treatment and device development at Houston Methodist Research Institute in the Texas Medical Center. Dr. Losh was an integral member of the team that oversaw the development of the first FDA-approved convalescent plasma therapy for COVID-19 and has helped them move the therapy to clinical trials. Our next expert is Dr. Robert Atmar. Dr. Robert Atmar is a physician scientist at BCM whose research interests include the diagnosis, treatment, and prevention of norovirus and influenza. Dr. Atmar is chief of the infectious disease service at Ben Taub Hospital in the Texas Medical Center and is a co-investigator of a clinical trial testing novel therapeutics, including remdesivir, to treat COVID-19 patients. And finally, our last expert, last but not least, is Dr. Layla Watt-Colburn. Dr. Layla Watt-Colburn is an infectious disease clinician and director of medical education for the National School of Tropical Medicine at BCM. Dr. Watt-Colburn actually started the first tropical medicine clinic at Ben Taub Hospital. During the pandemic, she's been involved with multiple clinical trials related to COVID-19 therapeutics. And just like our segment yesterday, is it okay if I refer to everyone by their first name so we can keep this more conversational and casual? Great, thanks so much, everyone. And like Amir had mentioned, please feel free to submit questions in our live chat in Zoom, Facebook Live, and YouTube anytime during the webinar. Our experts will be answering questions in our Q&A roundtable portion. Once we get through a few myths about diagnostics, vaccines, and therapeutics corresponding and surrounding SARS-CoV-2, we'll hand it off to Amir with Taste of Science to moderate your questions. So, to get started into our first segment, diagnostics. As COVID-19 spread rapidly in the United States, it became clear that infected patients needed to be identified quickly with testing to maintain the spread, but that never happened. We never had enough tests, and while our other countries with high testing rates were able to slow the virus down, we weren't able to. Aisha, a myth circulated on my own social media feed and other news outlets like CNN early on is that tested for COVID is easy, that anyone can do it. Is this true? And what does it take to develop tests in the middle of an outbreak?
Thanks, Bailey. Again, thank you everyone for being here, and thank you for having me here. I'm still training, so I'm learning on the fly, I guess, in the middle of this pandemic. So that's been a little stressful. But so when most people talk about diagnostics when it comes to COVID-19 and diagnosing patients with COVID-19, they're talking about the PCR test, which detects the presence of SARS-CoV-2 genetic material or RNA. Not the live virus. And that's kind of an important distinction that we can talk about later. But developing and running the COVID test is not easy. It's classified as high complexity by our standards. So clinical microbiology labs are experts in running these diagnostics. So it's not run at drive-thrus. That's just where they swab you. And when the pandemic hit, you're essentially developing a test for a never before seen virus. And normally there's a rigorous approval process to get tests cleared by the FDA. And now we know that because of the crisis, there's a faster track to get things greenlit. And that still means you have to demonstrate that the test is sensitive, so can pick up the lowest amount of virus, and specific, that it's not picking up another virus. And labs have to, again, verify the accuracy and precision of the test before they use it. So there's a lot of things that affect the accuracy of a test. And keep in mind, they have to do all of this while they're dealing with the immense pressure of churning out tests and finding resources to be able to even scale up and run sometimes thousands of tests a day. So not just the diagnostic itself, but we want to make sure that we're giving results that are accurate and actionable or useful. So it is definitely way more complex than it seems.
Awesome, great. Thank you for that great explanation about why it's not really practical or feasible to do thousands of tests at a time and how we can't do them in a drive-through facility or something like that. And it takes a lot of work and time to get a reliable test off the ground. But now that we have this test, can you explain why there are so many shortages in testing and why clinical labs around the country haven't been able to scale up?
So that's a very complicated question, but because we're dealing with different types of shortages. But yes, our labs are struggling with shortages, not just of tests, but of swabs to collect patient samples, protective gear medical workers need to even collect samples, and lab personnel to be able to run a bunch of tests. And that's essentially why we're rationing tests to our sickest patients with symptoms. And why is because labs need money to run tests. And initially, the government stimulus funding was directed and supplies were directed to big commercial labs, but not smaller clinical labs like ours in hospitals. And ASM, I know, has directly advocated for this, and I hope we can access more of that funding, but all commercial labs have released statements saying that they don't have shortages. But for us to be able to send our patient samples to a commercial lab, those results can take days. And early in the pandemic, it took weeks because of the volume. Our labs in hospitals, though, can get results back to our patients sometimes in a couple of hours, so much faster. And that is important. A fast diagnosis means that a patient could get access to a life-saving treatment faster. And there's also shortages in the manufacturing supply chain itself. Hospitals, I think, have been forced essentially to wage bidding wars against each other to secure supplies. And this chaotic market competition makes me worry. For example, if I'm scrambling to secure supplies for my lab, does that mean patients at another poor community hospital don't get them? So I think it's rough, and what we need is more resources. And I think ASM has advocated very well for that, but we also need leadership and coordination. So we're allocating these resources to the labs that need them.
Great. So that was touching more about this PCR test. So, but there's also been talk of this other test, the serology test. And to open the country gradually, a major proposed solution has been to perform this antibody testing to determine people are already immune to COVID-19. Are there any limitations to serology testing?
Yes, lots of limitations to all types of testing, actually, but specifically serology. So ideally, when we're talking about serology, we're talking about ideally it detects antibodies in blood, which are made 1 to 2 weeks after exposure to SARS-CoV-2. It should not be used to diagnose COVID-19 infection. That's what we use the PCR tests for, which are reliable, especially for symptomatic patients with an active infection. There haven't been a lot of peer-reviewed studies on COVID-19 serology, which is why it's hard to make strong claims. So first, the test itself has to be reliable and precise. And currently, the IgG antibody tests seem to be more reliable. And there were a lot of issues at the beginning with the lack of FDA oversight with questionable antibody tests being on the market. And I think with ASM's advocacy, they've revised those guidelines. So we now have a little bit more oversight. But if you test positive, even with an accurate test, that means you were likely infected sometime in the recent past. We don't know if the antibodies detected will prevent a future infection or immunity, like you just said. But a positive antibody test does not mean you're still not contagious. You could still be producing antibodies and actively shedding virus. And you could also get a false positive because antibodies could be specific to another common human coronavirus, which is, again, a huge issue when we're talking about some other types of antibody tests. And this can give you a false sense of security. And with a negative result, that might mean that you haven't been exposed, or it could mean that we're just testing you too soon, and you haven't developed enough antibodies for us to be able to detect them. So we need more studies, but I do think that serology testing is important and is going to play a key role, especially in surveillance. So we have an idea of how many people have been infected or exposed to the virus, which will give us a more accurate idea of mortality rate. And as we're talking about reopening the economy, I think it will also play a main role there, along with PCR testing as well, if we're doing it in a way that is strategized and knowing the nuances and developing an algorithm that kind of makes sense.
Awesome. Thank you for that really detailed and clear answer. So antibodies, like you mentioned, are one of the critical parts of seeing if you have immunity to something, and they're important for a strong, lasting immune response to infection. So let's dive in a bit more into how scientists are actively working on a vaccine to induce lasting immunity. Allie, can you tell us more about where we stand with developing a vaccine against COVID-19?
Hey everyone, I'm Allie Breuer, and I'm a science PhD candidate at UT Health. So another big question on everyone's mind is, when are we going to have a COVID-19 vaccine available? And a myth associated with this is that vaccine development shouldn't take long for scientists to come up with, and that we should have one available in just a few short months. However, that outlook is not in line with what it actually takes to develop a vaccine. Vaccines are hard to make because they contain complex components like proteins or even whole inactivated viruses. And the overall goal of vaccines is that they should elicit an appropriate and safe immune response in people, which will protect them from a virus the next time they're exposed to it. So I can't stress enough how important they are to protect those who are unable to get vaccinated because of an underlying health issue they may have. So basically, scientists have to develop vaccines starting from their discovery on the lab bench, but then further test them in animals and then in humans before they can be assessed to the public. And the bottom line is experts have to make sure they're safe and effective, which takes time. So Robert, I know that you're an expert on respiratory viruses and actually oversee vaccine evaluation at Baylor College of Medicine. Can you fill us in on any promising candidates being studied at Baylor and what stage of development they're in?
So right now, the only SARS vaccine that has been developed at Baylor was one that was developed by Dr. Peter Hotez's group for the original SARS coronavirus, now SARS coronavirus 1. And that was a vaccine that targets a portion of the spike protein. The spike protein is a protein on the surface of the virus that is important in initially binding to a cell so that it can initiate infection of that cell and generating antibody in the person's body against the spike protein may actually block the ability of the virus to infect the cell. And the antibody in the vaccine he developed in his group targeted specifically a portion of the spike protein that interacts with a molecule on the surface of the cell to initiate infection. We call that the receptor binding domain. And so that vaccine has been taken up through animal studies, but it's not yet been into people. To date, there are, I think, 7 clinical trials of other candidate vaccines that have begun in people, and close to 90 different vaccine candidates that are either in clinical trial or in what we call preclinical. They're being tested in the laboratory before they are ready to be tested in people.
Thank you for your insight. So Robert, when do you expect that a COVID-19 vaccine will be ready and accessible for everyone so that a large percentage of the population is immune to the virus?
So I only heard part of your question, but I can anticipate what you said. There are several stages that a vaccine has to go through in terms of being ready or before it's ready to be used in the general population. We tend to call those phases of the study preclinical, which is where it's tested in the laboratory and in animals. Then we have phase 1 testing, which is when it's first given to people to make sure that it's safe. And generally speaking, in the phase 1, we also look to see if there's an immune response to the vaccine. In phase 2, we give it to more people and beginning to give it to people who are the target population, which right now would basically be everybody, or at least everybody who hasn't been infected previously. And during that phase, we're doing further evaluation about the immune response and selecting a dose that's appropriate to give to see whether or not it's protective. And we also, in late phase 2, may get some preliminary evidence about whether the vaccine may be effective. And then phase 3 is a study where it's given to large numbers of individuals in a clinical trial, such that you look to see whether or not those who receive the vaccine compared to those who don't get the vaccine are protected from infection and or illness and or the complications of illness to determine whether or not the vaccine's effective. Also, this is generally the phase in which the largest number of people receive the vaccine, and you determine whether or not the vaccine is safe and whether or not there are any unexpected adverse reactions or side effects that would mean that even if the vaccine worked, the side effects are unacceptable and would not be generally useful. Usually going through all these different phases takes a number of years. I think the average is probably somewhere between 10 and 15 years. The shortest period of time from beginning to work on the vaccine in the lab to having it rolled out for use in people, I think was back in the 60s when the mumps vaccine was developed, and I think that was 4 years. NIH and the government reported over or stated at the end of the week that they have Operation Warp Speed. For those of us old enough to have watched Star Trek in our youth, that has maybe more meaning than it does for some of you Star Wars age people. But anyway, and the goal there is to go through all of this and have the vaccine ready by the beginning of 2021. And what I didn't talk about was after phase 3, usually there's a period where one has to gear up and make enough vaccine to be able to give it to people who will receive it to be protected. And that often takes a while to get geared up. And so all of this is trying to be collapsed in about 6 to 8 months now.
Okay, wow. So that was a lot of really great insight. Thank you for your comments, Robert. So it seems that progress is definitely being made towards finding a new COVID-19 vaccine, and there are already candidates being tested, which shows how hard scientists are working. So in addition to vaccines, we also need to develop treatments to help the people who are already infected. And from my reading, there's been a lot of motivation behind this. Fred, can you please tell us more about COVID-19 treatments?
Yes, Ali. Hi, everyone. I'm Fred, a PhD candidate at Baylor College of Medicine. Right now, over 1,000 clinical trials related to COVID-19 have been registered. There's no cure yet, which generates public fear and uncertainty. Several treatments have shown rather promising preliminary results, which give us hope. One of these treatments is to transfer the plasma of recovered COVID-19 patients with antibodies against the virus to patients with an active infection to enhance the immune response and cure the virus. While there has been positive preliminary results, it can still take time till the public can access such a treatment. So Jill, can you share with us how long it took to get this trial approved and off the ground in terms of regulatory hurdles, and what's the current status of this study at the Methodist Hospital?
Sure. So it's kind of an exciting time for us in the regulatory affairs field. We started working with the PI on this convalescent plasma therapy trial in mid-March is when it came to our office. I think actually it was the day that the rodeo shut down here. So that was maybe March 13th or something like that. And we worked on that about nonstop for the next week or so, putting a lot of our normal everyday projects on the back burner for a bit, as many people are doing in science. And we received approval within just a few weeks. This is obviously not normally how things go when developing any other medical device or drug, but this was an emergency. Well, it started off as emergency use application and since then has been expanded by the FDA. So I do want to point out that convalescent plasma therapy is widely used. I'm not sure if you guys are familiar with the history of this, but it's been used in some form or another against both bacterial and viral infections since the 1890s with varying degrees of success. They've been talking a lot on the news about how this has been used, or how it was used during the Spanish flu, which was the first virus that this therapy was used for. And obviously that was 100 years ago. Some of our records aren't as detailed now as they are now. But after use in the Spanish flu, it was also used to a small amount in the H1N1 breakout, Ebola, SARS, and MERS. And so for us, while the degrees of efficiency have been varied, as I said, we felt like it was a good thing to try, at least for this first wave of infections, because the treatment itself is fairly safe and widely used. Just the process of transfusion, I think we all know is fairly common for different diseases, plasma, platelet transfusions, et cetera. And so this was just something that was fairly easy for us to push through just because of that history of it.
That's very exciting, and we hope to see more positive results soon, since both Baylor and Methodist are starting to similar trials and enroll patients. I know that one another popular candidate to treat COVID-19 is remdesivir, an antiviral medication originally developed to treat Ebola. Actually, last week, a study showed that it might speed up recovery of the COVID-19 patients, and it has been granted emergency use of authorization for severe COVID-19 by the FDA. So I wonder, Leila, that you are part of the remdesivir trial at Baylor. Could you tell us more of what's the current stage of this study at Baylor, and what's the difference between an emergency use authorization and a FDA approved treatment?
Thank you. So actually the person that probably knows a little bit more about the adaptive trial is Robert. So the adaptive trial is an NIH sponsor where we did the first phase where it was placebo versus the remdesivir, and had enrolled, and last week was kind of busy. It kind of, you know, there was the hashtag of Fauci leak and how it came out with the Lancet and had a pro and everything. So now there is an Act 2 to that adaptive trial after that. So we don't know. I mean, you know, I mean, was a blinded study. So we had patients who received placebo and other patients who received the drugs. You know, from what the data was released is that one day was, you know, it shortened your stay in the ICU. It shortened everything. But I think what we learned most is that this antivirals work at the, you know, at early stages. I mean, you really want to give it once the viral load is coming down and you're starting your inflammatory phase, kind of on a sweet spot before the patient ends up intubated in the intensive care unit. I mean, even one day to shorten that period, it gives us a lot. One is a health cost because you don't have one more stay in the ICU. And the other one is that you free up the intensive care machinery and people. So overall, it makes sense. I mean, it works on the RNA polymerase. It's a good antiviral, and except that, you know, for if you have your creatinine clearance is below 50, it's an issue because it's still IV. Ideally, we would like to see is an oral one, something that you can give, because if you want to disseminate this globally, giving IV access might not be something feasible for all the global community.
Thank you for your information. It seems that there is definitely progress towards finding a treatment. We know that although there's no cure yet, almost 1 million patients worldwide have recovered, and we hope that there will be treatment available to public soon. And for that, I'm going back to Bailey to answer more questions.
All right, that was great. So now that we've laid the groundwork for talking about our path moving forward, we're going to hand it over to Amir, our friend from Taste of Science Houston, to moderate questions from our webinar Google form and from our Zoom, Facebook Live, and YouTube chat. Take it away, Amir.
Thanks, Bailey. Wow, that was a lot of information. So just to keep everyone on the same page, we're now going to shift to questions that our own viewers have submitted before we started this entire webinar. Let's start with, so many times as our economies are opening back up, we're seeing that companies are using so-called thermometer scans to dictate whether or not somebody can come into their business or come into their workspace and whether or not they're infected. Is this really effective, or is this all smoke? I'm going to post this one to Leila. So
we use temperature screening as part of a way of getting into the hospitals. We know that in about 75% of the patients who end up in the hospital will have a temperature. So it can be an early marker. But the one that I like the best is if you can smell your coffee. The anosmia, or the loss of sense of smell, precedes everything. So if you can smell your coffee, probably you're good to go.
Oh, wow, that's really interesting. So we have an early readout that even people at home can do to say, oh, is there something that I should be worried about? Okay, so this gets piggybacking off of that question to you, Aisha. I know that you're working on detecting the virus as early as possible, but a lot of people out there are really concerned about asymptomatic patients. And the question is, how are we going to go ahead and screen to see what the real mortality rate and the real infection rate is out there?
So I guess I'll answer that in two parts. That kind of goes back to my earlier point where it is really important for us to be able to screen a sizable amount of the population to be able to understand how many people have been exposed and how many people have it and are recovering, et cetera. But again, the limitation there is the shortage of testing. But even with resources, we don't have enough people to run tests. So I think there's thousands of research microbiologists that are sitting at home with PhDs or graduate students. So with the program to recruit, accelerate training, and funding, they could be deployed to run tests. And two, specifically, because there's a lot of community transmission that occurs from asymptomatic or pre-symptomatic people who are shedding the virus. The solution there is to have designated task forces essentially for every state who can coordinate surveillance. And most importantly, I think it's a tool that now people are talking about to reopen our economy. But the one thing to keep in mind though is our PCR tests that have been built to diagnose people with symptoms. So we need studies to know if we're not missing asymptomatic or pre-symptomatic spreaders with a false negative result. So we need a clear strategy, which is incremental opening, where we prioritize testing select groups of people and maybe assigning them into risk categories. So for example, if a person tests positive by PCR, but negative for antibodies with serology testing, could be considered high risk and needs to be isolated. In contrast, someone who is negative by PCR, but positive for antibodies could be considered low risk. But again, you need to keep retesting them because a negative PCR today could be a positive PCR tomorrow. So that strategy, combined with the social distancing and all other public health measures as we undergo this transition, I think is going to be the way out of this to understand asymptomatic spread and eventually give us a better understanding of mortality as well as we test more people.
Interesting. So it sounds like you're really calling for a very wide net and trying to tackle this COVID pandemic on all fronts, and no one solution is going to be able to get us out of this. We're going to require multifactorial approaches. I think many people have also said the same thing. Robert, would you like to add?
Yeah, could I add to the answer? So one of the questions, I think it is a marriage of both PCR-based testing and serology-based testing. And one of the ways to figure out how much asymptomatic or subclinical infection there is through epidemiological studies where the population is tested for the presence of antibodies. So this is using an antibody test not to look at an individual, whether he or she may be quote unquote protected based on prior infection or presumed prior infection if antibodies present, because we don't know that yet. But what it's doing is looking at the population and saying 10%, 15%, 20% of the population has antibody. And then you look at the people who are tested and ask them, have they had a respiratory illness or febrile respiratory illness over this is a relatively short period of time. We're talking about going back to the beginning of January. And did they have such an illness? And if they didn't, they had an illness or infection that was not recognized as being COVID-19. And it gives you an idea of what percentage of the population has symptomatic or what is the penetrance of the disease after infection. And that'll give you some idea about the transmission dynamics. And those kinds of studies are now beginning to be done in some populations. And one of the things that's concerning is even in a place like New York, where they've been overwhelmed, the seroprevalence studies have only shown that about 20% of the population has been infected. So there's a lot to learn, and we're certainly learning as we go with this, but that epidemiologic approach is one that will take a while, but one that will ultimately inform us how often infection ends up causing disease.
Yeah, I completely agree. And I think both your answer and Aisha's answer really complement nicely with Layla's answer, who provided a early warning that people can do at their home to know whether they're really sick or not. I think many people that I've talked to have said, do I have allergies? Do I have a cold? Or do I have COVID? And it's nice to hear that there's approaches on all the fronts.
I'll just mention that, yes, if you can't smell your coffee, there's a chance that you are infected. And that has been the first symptom for a number of patients. But by no means all patients have that. And so one of the challenges has been this is a disease or an infection that has caused a wide variety of clinical presentations, which has made it a bit of a challenge to recognize. And yesterday, I think you went through some of the challenges from an epidemiologic standpoint in terms of transmission, but it remains, a question. When a person has symptoms initially, is it just due to some modification or variation in their underlying health, or is it in fact a supervening coronavirus infection? And it may take a day or two to figure that out.
And I think there's been a question about herd immunity. Just to, I guess, clarify what that is, it essentially means that there's enough people that have been exposed to a disease such that we are not worried about it transmitting extensively. And that number, exact population number, how many people need to be exposed varies, the precise threshold of what population needs to be immune. But for SARS-CoV-2, that remains to be defined. But assuming that the reproductive number ranges from 2 to 3.5, there have been certain preliminary estimates for the threshold being 40 to 75%. So that's essentially what herd immunity is.
Thank you, Aisha.
We're well away from that.
Yeah.
Let's take a side track now. Jill, this question is to you. I think you're our regulatory expert on the panel today. Now, we've seen multiple examples on cable news and government press releases about so-called impromptu hospitals being set up. And I was wondering, could you shed some light as to how difficult it is to set up such a facility? What goes into trying to get that type of man force mobile?
Sure, it's very difficult, and unfortunately, not only is it difficult in setting up these new pop-up care facilities, it's also just been difficult at the hospitals themselves. And we're talking about, hospitals in the largest medical center in the world here in Houston, who, in theory would be the best to be set up for any type of pandemic, but it's just not how we operate normally. So in setting up the pop-ups, and even, I'm just going to expand and just include our own hospital in this. Nearly every nurse and physician and administrator like myself has somehow, like I was mentioning earlier, has had to drop normal duties to some extent, at least, to pick up the slack and take care of things here. Many wards and hospitals that were previously used for something else have been repurposed. So perhaps patients who don't suffer from something infectious such as this can be combined to a safe extent. so that we can use some of that space now to expand and use for COVID patients who are extremely infectious and need different barriers put in place. For the pop-up facilities, it's been difficult. We've seen on the news, so that the Mercy Hospital ship in New York, they chose to just use that for non-COVID patients, so that they could use hospitals and the Javits Center for just COVID. But then some places have taken an opposite measure where they've opened up a pop-up just for COVID and not for anybody else. So it's really been, I don't want to use the word experiment, just, but I guess I should. It's been trial and error, right? To see what works best, to just open something new just for COVID or open something new for other things that are more easily managed. So it's been a long month or so, but I know that many hospitals and hospital systems are finding their pace. They're seeing what works. In Texas, we have been lucky that we didn't get hit as hard for this first wave as New York so far, and so it bought us some time, right? So that a lot of our COVID wards are established now and set up, and then, tying into therapies such as the convalescent therapy, remdesivir, et cetera, the number one most important and exciting things about these treatments are not that they're cures, but it's that, as Layla was saying, they're just taking time off of the patient's theoretical time of hospitalization, time on oxygen, time with ventilators, so that someone else can use those. So,
thank you. That was a very terrific answer. Robert,
So
you want to
can I-
add something?
Yes,
Go for
you
it.
can read my face. So in fact, we've had experience in doing this previously back in 2005 with Hurricane Katrina. Houston received a number of evacuees from Louisiana and New Orleans specifically, and really to set up these kinds of medical care facilities required, and we had the political will to organize it. But you have to find the medical supplies to be able to set up the hospital, if you will. You have to find the clinicians and support staff to provide care and support of the patients who come in. You have to figure out ways to do laboratory testing, radiology, infection prevention, particularly when what you're dealing with is a infectious disease. And so it's not simple, but with the political will and leadership, it can be done. And it was done successfully back in 2005. Our local leadership also set up a system at Reliant in anticipation of a need for overflowing from the hospitals. And as Jill noted, we've been fortunate in Houston not to suffer the excessive patient burden that has been seen in places like New Orleans, New York, and Seattle areas and other parts of the country. So, but it's not just putting up the equipment, it's finding the people to staff it, figuring out the methods to get the services provided and to track your patients through that process.
Oh, absolutely. It's definitely a gargantuan effort to get such a huge machine up and running. And I think I'm going to pivot now to Layla for a second, because I wanted to ask, I think it's the most difficult question that our users have asked. So I'm sorry that you've been deemed the necessary target. I'm going to ask this question, and it's okay if there's no right answer. Just what is your answer? And if anybody wants to chime in with what their answer is too, I think the general public would be of interest. What sort of new daily case numbers would you want to consistently see in order to open up our country? I know it's a difficult question. And then there's a second question to even make it tougher. what do you think we can do to prepare for a so-called second wave once we open up our country?
So it's an interesting question, because I think you have to see the United States. Each state is different, and how it has been affected is different. So it's a unique. So just like what Robert said, is what works in one place doesn't work on the other place. You know, I think you have to have certain things in place. You know, your testing capability, look at your local capability of taking new cases, and also the culture. If we divided, for example, I mean, in the South, we're going to have a lot of healthcare disparities, and we see that just on chronic health overall. So what works for us might not work. So it's difficult. The number of cases you really want is, you don't want any cases, right? That would be the ideal utopic world. But it's best to think, and I got posed this question by some of the Latin American countries that I frequent do talks, is that what you're looking at is at a gradual opening. And you want to do a gradual opening, but still remain with the mask, the social distancing, the washing of your hands. And I think I was reading some of the questions, they had mentioned some of Sweden, and think actually the best country that you should look, actually two countries, is what Germany and Taiwan have done. I think Taiwan has done a spectacular way. That the prime minister was very key on and they didn't shut down the whole country. And it was very specific on what they wanted to do, but also the community around came together. Germany is different because they've done into the massive testing like Korea. And then the other country to look at what's going to happen is New Zealand, because New Zealand has reported 0 cases and they will be opening it up, and it's an island. So short is you want 0 cases, which is the utopia. The US has to be individual, and it's going to be a gradual new normal for the next, who knows, until we have a vaccine or we have better treatments and we can go.
Yeah, I think I want to echo what Lila said about the incremental opening, that there's no on and off switch to this, where you just go back one day and everything's okay and we see the case rate that we want to see, and you know, we're good. So I think doing incremental opening where you're testing subsets of populations, separating workforces, prioritizing workforces based on who needs to go back, and moving from there in steps, I think that also makes it more reasonable for testing. Just given the amount of shortages and supplies that we have. So I think that's most important to understand, that this is going to be a slow, long process. And while it's happening, we need to continue with social distancing and continue with all of the public health measures that are in place right now.
Yeah, fantastic. Those are wonderful answers. And thank you for highlighting. Oh, Robert, go for it.
Yeah, you know, I've got an opinion about everything. So one of the reasons that some people have been concerned about the opening at this time is that from much of the modeling that's been done, the suggestion has been that one of the criteria is not necessarily an absolute number, but a declining number of cases in a region or locale for at least 10 days, which suggests that and that's just under one full incubation period. And we locally have not, or at least in our state, have not achieved that. And that's not been achieved in some of the other states that have been opening up. And so I think that's why you hear concerns raised. I agree with Lila that 0 cases would be ideal, but I don't know that we're ever going to get to 0 cases. I think this virus may be with us to stay because it's already so widespread. And unlike SARS-CoV-1, where the measures that were taken, epidemiologic measures such as social distancing and quarantine isolation, was successful because there was a much higher penetrance of disease. People who got infected were fairly easily recognized, as opposed to large number of asymptomatic and mild illness that we're seeing that allows more ready transmission.
Yeah, thank you very much for that. I think that was really useful to understand this context of virulence and how difficult it is. There's a certain sweet spot for a virus to live in that I think that was covered yesterday. All right, Jill, I think we have one more question from this roundtable, and then we're going to shift to a very long list of questions that we have from our live Q&A session. Many people are concerned about how this is implementing their daily life, and that's really understandable. Nobody's life likes to be disrupted like this. This is a difficult question, but is there any advice that you would give people who have to travel? And what is the way that they could do this in a safe manner? This is both, sorry, one moment. This is both public transportation and flights. They made sure to mention this.
Right, okay. So I know it's been tough. I myself have had to cancel a trip to go see my own family during all of this. And I know that some people have similar situations, and those will continue to come up, obviously, for the next year or so that we're living in this situation. It is interesting that, you know, some of the airlines have put things in place, the mask requirement, et cetera. But some have not. I do think that we'll probably see a shift so that all airlines will go ahead and require those measures, masks, gloves. I anticipate that due to pressure. I know the airlines want to start back up with their business, and it's a way that if they do encourage or require passengers to wear PPE, then perhaps they can try and get up to maybe not quite normal levels of passenger, what do I want to say? People on planes, I guess, but somewhere up to that normal level. I think that if someone needs to fly, which then I'll get to the driving later, if someone needs to fly, that is not, in my opinion, up to the public to judge them for. There are different reasons, whether it's for their job or a sick family member or a funeral or something like that, that they need to go for, they need to go. I would just recommend for them to try and be as safe as possible, social distance to their best possible capability in something such as a bus or a plane. We can just all do the best that we can. I think that I do understand why there has been a lot of anger towards people that it seems they're not doing enough, or they should stay at home, or they shouldn't do this. I know that a lot of that is fear-based, and a lot of it is not unwarranted, but I think that it's not exactly helping sometimes. And so I really think that the number one thing is for people to just do the best that they can. In terms of driving, you know, if someone needs to travel and they're able to drive, that would be better than taking public transportation or a plane, because obviously you're in your own car with just yourself or your immediate family members or friends. The things to remember in terms of road travel, you know, would be to try and keep masks and gloves in the car. When you need to stop and fill up your tank, you know, try and wear gloves for that, or bring some sort of wipe or ethanol, anything you touch, right? Gas pump if you go in to use the restroom, just things like that. So just be precautious.
And Amir, I just want to, I guess, raise the point that especially in urban cities where there's limited methods of transportation for people that are traveling from far away, public transportation is the only option that they have. For example, in New York, healthcare workers, grocery store workers, sanitation workers were packed into the subway system, and that's the only option that they had. And that's because we need to be able to come up with alternative ways to find resources and provisions for our frontline workers, essential workers, to be able to get to work. And I think that's a falling not on the part of the people that are trying to do their best, but on us to be able to come up with systems that allow them to.
Well, and I do want to add to that really quick. So I think it is encouraging that places with such robust transportation systems, so New York, you know, we don't have that so much in Houston, although we do have our own rail and bus system. It's encouraging that the cities have stepped in as soon as possible to come up with the cleanliness procedures for the trains and the seats on the buses, et cetera. I think that, you know, there has been argument that they should have shut things down completely, but as you pointed out, Aisha, that's not feasible for everyone. For example, even, you know, nurses, they're not even in retail, nurses who literally have to go to work to help with this, and doctors as well. I should open that up to all health professionals. They have to get to work. And, you know, I think sometimes it's taken for granted that we are a nation that runs on car power, but not everyone has that capability. So I do think it's been really great to see that level of new policy changes to help maintain the cleanliness of the buses and the rails. And there's even some places that are giving out free gloves and masks whenever needed as well.
Wow, thank you so much. And I think the point that you made about how we have to be compassionate to everybody's use case and not think that a one size fits all in such a diverse economy and culture was really on the nose. And Aisha, thank you so much for chiming in about the fact that you're right. Some people don't have another option. So it's easy for people to say you can't take the public transportation, but if it's the only one you have, then that's much more difficult. Okay, so thank you so much for that roundtable, and for everybody that submitted a question beforehand. Again, thank you for your participation. We're going to shift now to our live question and answer session. So you can still ask questions. We have a very long list, but we'll try to get through as many of them as we can. Okay, who here has a pet? Fantastic. So this is first to the pet owners, then, because it's a question that's come up now in both days, which I think is really interesting, and it may fall under the myths and misinformation. Can our pets be infected by COVID? And if they are, can they infect us back?
So I'm going to step in real quick with that. In my previous life, I was a vet tech, so I'm a little passionate about this. And I love to talk about my dog, so you know that works. So as far as I'm aware, there is no evidence that a pet can actually become infected. And what I want to say is infected is not that they're a carrier, but that they're sick with COVID, that the virus has started a systemic infection within the animal. No, there's no evidence. And in fact, it is rare that we see this in anything. So for example, a lot of people have dogs that are vaccinated against canine flu, right? So that's a rhinovirus, just like the human flu, but it would be dog specific in general. So there's no evidence of that. I know that there has been some headlines, and I think some of these headlines are a little bit hyped up, that dogs can, or house pets I should say, can be carriers of it. Some of these articles I think need to be taken with a grain of salt because of the language that's used in those. Yes, there has been instances where an animal's nose was swabbed and viral particles were found, but then we also have to remember they live within us, we're cuddling with them. If you're sick, you know, their noses are wet, something's gonna stick to it. But I do wanna just make it clear that no one has had a pet that they've said, oh, it also has COVID-19.
So I want to chime in. So there has been data of human to animal transmission, and this happened on the Bronx Zoo with their tiger population. So as a disclosure, my sister is a veterinarian at the Nashville Zoo and a former alumni of Cornell. And so Cornell has looked at it, and there's also been information on transmission more human to the animal. And all this comes from a feline coronavirus that was detected first in Hong Kong, where it is. And then there's been a couple of New York incidents where people with what we presume high viral loads have been able to transmit it to the feline population. Now, the puma and the two tigers in the Bronx did well. they didn't develop acute respiratory distress, according to the Bronx Zoo. But I don't know if Robert has a little more information on that.
Yeah, so, I think we have to remember that the SARS coronavirus probably originally came to infect people from a small mammal. The postulated animal was pangolin, which is an anteater-like mammal. And with SARS and some of these other zoonotic viruses, it is possible for other mammals to become infected. The reassuring piece for Jill and the rest of us pet owners is that even though pets may be able to be infected, it's not clear that they can then turn around and infect other people. But the risk is there, and I think what the CDC has put out is just be cautious, but be reassured that pets are not a major way that this virus is transmitted. So is it possible? Yes, it's possible. Is it a major problem? No, it certainly has not been a major problem to this point.
It's wonderful. Thank you guys for that. I think going forward, these are the types of questions that are on people's minds, and I appreciate the very thoughtful answer to them. Aisha, I think this next one's to you. You mentioned before that maybe there's a so-called call to arms for anybody that can do clinical work to help participate in the fight. And I think going forward, at least based on our audience's questions, that's really on their minds. And they would like to hear, do you know of any venues that PhDs who maybe are not specialties in this field can still help contribute that you could share?
Yeah, so I don't want to, scale down how difficult it is to be able to do this. They still would need to be trained and be able to be equipped and supervised by clinical microbiology lab directors that are licensed and certified. So it's very institution specific, and it's also state specific guidelines and rules to be able to do that. I know there are universities, for example, the University of Washington and the University of California in San Francisco has been able to recruit graduate students as well as other researchers that have high complexity skills, and been able to train them, accelerate that process of training, and deployed them into labs where they are doing tests under a supervised manner. So it is safe, and it is under a lab director that has the right training. But in order to be able to do that, we need to be planned for it and be ready to go, essentially. So it's kind of like a national guard, I would say, of researchers that we have. And whenever something like this happens, we have a program already ready to go where we have the funding allocated to be able to recruit a small portion of them, train them, and then deploy them where they're needed, especially in places that have high volume of tests where they need to do thousands of tests a day, but then don't have enough personnel. So it comes with pre-planning, and I think that's kind of been the difficult thing for us. We need the help, but it's hard for us to understand how to have the capacity to do that. We need money. We need to be able to pay people to do this. We need to be able to have the resources. So I think that's been what's difficult. There's a mechanism to do it, but it varies by institution and states.
Wow. Sounds like you just described really mirrored the way Jill described having to set up an impromptu, and Robert also mentioned hospital, is that on paper it seems like it can be done, but when you try to put it into the real world, it's very difficult. Okay, Jill, I think it's not an exaggeration to say you are the plasma expert on this panel. So I think this question goes to you. Can we collect sufficient plasma from recovered patients so that we can start treating patients that are becoming infected? And maybe before you start that, I would ask just one description. Can you describe for the audience what's the difference between plasma and blood?
So plasma is basically the liquid part of blood, right? As we know, just from elementary school, and blood is made up of many different cells, including the red blood cells, which is what gives it the color, the little donuts, and platelets and other things. So plasma is the liquid component. So I do want to say that, yes, that was a concern early on. Will we get enough plasma? Will people who have been sick, either at home or in hospitals, really want to come out to donate plasma after they've deemed to be recovered? And it's been really nice to say that the answer to that is yes. A lot of the blood banks are reporting high numbers, and especially high numbers of first-time blood donors during all of this. So that's been really fantastic, really encouraging. When we started up our clinical trial, we did have that concern that perhaps we wouldn't receive enough plasma donations to continue the trial to the level that we wanted to start with. And so we did stipulate that in the trial itself, which was originally for 50 participants to get plasma, that we would do interim analyses after the first 10 and the first 25 patients. And some of that was put into part because it was, oh, what if we don't actually receive enough plasma to reach that 50? We did, and in fact, we've received so many donations from previously infected donors that we're expanding the trial, and it's obviously continuing. So that's been great.
That is wonderful. Wow, it's always nice to see people are coming back to pay it forward. Okay, Robert, I think it's no exaggeration to say maybe you're the vaccine expert on this panel. So there's two tough questions about vaccines that have been suggested. Yesterday, somebody noted that it's been reported that there's over 400 different strains now detectable of COVID. Is it going to be possible to generate a vaccine against all of these strains? And maybe you can tie into this the subtleties of generating a vaccine against a virus that mutates.
So coronaviruses are RNA, they have RNA, ribonucleic acid as the genetic material. And those viruses do mutate such that almost with every round of generation of new viruses, there's at least one or two mutations in the gene. And this virus is a big RNA virus. It's got almost 30,000 nucleotides in length. So to say that there are so many different strains is just to say that you have a large number of viruses that have different sequences. What that means in terms of being what we call antigenically different, which means that the immune system does not recognize one virus compared to another, like we see with influenza when we see strains change from one year to the next. Whether that occurs with coronaviruses is not yet known, and in fact, today the hypothesis is that that's not the case, that despite all the different sequences of viruses that are out there, almost all the vaccines that are being developed are targeting the spike protein, and in particular the receptor binding domain portion is very highly conserved. And so it's probably not going to be as difficult if a vaccine is effective for it to protect against the different strains. That doesn't mean it's going to be easy to make a vaccine. There are huge issues we haven't yet discussed about some of the issues that need to be addressed before a vaccine's deemed safe and effective.
Yeah, thank you very much. I think that answers a lot of the questions. I'm going to ask the next question to the entire panel because I think it would be doing it a disservice to ask it to just one person, because multiple people have expressed this concern. It's kind of a difficult one, but look, we're going to open up the economy, it seems. And no matter what, we have to find a way to balance what the science says and what political and societal will demands of us as we move forward. So as we open up the economy and our jobs, in addition, as we start to open up potentially schools in the fall, what would your headline or advice be going forward to both maybe even our politicians and society as a whole. So it's to the public. So whoever wants to answer this one first, but nobody feel that they shouldn't answer. Somebody has to answer though.
Nobody wants that one because that's
No,
tough.
it's a tough question, right?
Yeah.
So I think is the first thing is that this is going forward. We're not going to be like it was December and January. There is a new normal. I think that's the reality that is a little harder. I mean, yes, the economy has to be open. I mean, we need to move on and do that. And that happened 100 years ago. I mean, the economy continued and there was a war and the war continued, you know. So I part of it is to the public is that we are going to have to continue our social distancing and are going to continue doing the mask and the washing of the hand. And I think the hardest part for certain parts of the economy are going to be concerts and sports events, because those large gatherings of 20,000, 30,000. You know, I'm a big baseball fan, so not being able to go see the Astros is a huge issue. But at the same time, there is part of it of the transmission. And I think the other part is going to be, you know, knowing what types of serology are we going to do, like Aisha said, this cohort parts, and how can we assure that you have enough preventive measures so people don't get infected from one place or another, right? So it's the $1 million question.
Yeah. Oh, sorry, Robert, do you want to go?
I'll follow you, please.
Yeah, I think I'll follow up with exactly what Layla said. I mean, I agree with the incremental opening, and sections of the economy will open, and we have to be patient in the meantime, as we're told to stay home, because some of us are not going back to work. But I want to be forward thinking about this too, that I think allowing scientific evidence to guide the reopening is important, but it's also extremely important to allow scientific evidence to guide long-term policy change so this doesn't happen again and we're able to be better prepared the next time, because we're in this position where we're dealing with this to this scale because we didn't do this early enough. So I want to also echo that besides the prevalent studies, and besides the surveillance, and besides opening sections of the economy by testing people, there's going to be long-term change that we need to think about in terms of making sure that we are providing vulnerable populations and high-risk populations with the resources that they need to be able to stay home when we're asking them to stay home. And I think that's going to be my one bit here.
What I would say is that recognize that this is a pandemic that the world has not suffered through anything like this. Since we've had the the global transportation and ability to circumnavigate the globe with while an infectious virus like this has been about. And so I think the public needs to recognize that things change, and what is recommended as a public health recommendation today may well change next week, and it's changing based on circumstances. Every recommendation that's made is trying to balance the public health good versus the potential public health or other public, say, economic harm. And that balance may change over time, leading to different types of recommendations. And so just be prepared to see that what we recommend next week may be different than what we recommended last week. And it's not because we got it wrong last week, it's because things have changed and we're trying to respond in the best way possible.
Jill, do you want to jump on this grenade, or okay?
I was going to say exactly what Robert said, that what's true today may very well not be true tomorrow. I think that was a perfect summation of that. And I think that, you know, while everyone has maintained some level of flexibility for this last month and a half, 2 months that we've been home. We're just going to have to stick with it. I think that, you know, as we all see from social media, people have been super creative on dealing with not just schooling their children, but just being social, getting information, such as what we're doing right now, having happy hours. I think that's been really nice and touching. I think that it will continue because we are resilient. And we'll just have to keep rolling with the punches until a vaccine's out and distributed widely.
Wow, that was really wonderful, guys. Thank you so much. The idea of adjusting to a new norm and realizing that a feature of science is that we change our statements, not a negative of science, is really on the nose, along with the populations that need to be taken into consideration the most right now. Really, really well done. Okay, for some people, you know, the world moves on and pregnancies are happening in the time of COVID. And now 2 days in a row, we've heard concerns about the transmissibility of the virus to the newborn. Has there been any work on this, or can anybody comment on it?
Well, I can make a couple comments, but so, I mean, people are certainly looking for it, and it's clear that a newborn can become infected very early, and young children can at times have very severe illness. Fortunately, it doesn't, and for the pregnant woman in the last trimester, having a high fever can lead to premature contractions, premature delivery. And so there are consequences. We're still trying to learn exactly what those consequences are. Fortunately, it has not been as bad, if you will, in this population as it has been in other age groups. But there are people looking at it and trying to figure out exactly what this infection means for the pregnant woman before she delivers, and then what to do if mom is infected and say the baby's not infected. You know, does the baby stay in the hospital or go to another family member until mom is no longer positive? These kinds of issues are being dealt with on a daily basis, and different OB groups are handling this with their pediatrician colleagues in different ways, because there is no one answer, although there is guidance from both the OB and pediatric societies on this. Not being a pediatrician or an obstetrician, I've not read those guidelines.
So it sounds like your advice would be talk to your OB/GYN doctor, and they'll be informed on what would be the best route with regards to COVID.
Yes.
Perfect, thank you. Okay, we have another panel-wide question because it's so big. As we start developing drugs to treat COVID and to induce so-called herd immunity, how are we going to address the problem of accessibility and affordability throughout the community so that we're actually able to achieve this goal?
So I want to step in on that really quick. That's been something that I think a lot of people aren't thinking about. Whenever they say, oh, we're going to have a vaccine next year, everyone's like, yay, we're all getting a vaccine next year. And it's scary to think about that may not be the case. There is going to have to be a lot of policies put into place to perhaps determine that, you know, some populations would need to get it before others. So for example, that may be the nursing homes. And the other thing that I think we need to just be thinking about is not only cost. And so the hope would be, just as we see with the flu shot, that it would be cheap and widely available to many people for free. I can't speak on if that's going to be the case, but it's just something to think about. The other thing too, in terms of widespread distribution, there has been there's been some recent headlines and also discussions that as we have many different vaccines in development right now, it may be very necessary for some upfront funding to go towards some of those companies or institutions developing those vaccines before that testing is actually completed. So a lot of money would need to be put forth to say, yeah, go ahead and start manufacturing this in high enough levels so we can be ready to go. It's sort of just a gamble there, a down payment, right, on something that may not be the best vaccine choice, but we're just going to have to continuously use our scientific knowledge to try and determine that as all these different vaccines are developed by the different companies.
There are government programs in place to make vaccines available to the underserved, and that can be through Medicaid or Medicare programs for older adults. It can be through vaccines for children. So there are ways of doing it. Presumably this would be available for those who have insurance if it's effective through insurance. And so, I think Jill's hit on the larger question about enough vaccine being available. And there's been some discussion in the press by government officials about producing vaccine at risk in the hope that it's shown to be effective so that they'll have more at the time that it receives approval. But the reason it's at risk is that there's a chance that there will be a safety issue or a lack of efficacy issue. How effective does it need to be worth vaccinating? Is that 90%, 50%, 30%? What level do you need? Even a 30% effective vaccine could have an economic impact and health impact, but that's much below what we would usually want to see in a vaccine.
And I also want to mention that a lot of our scientific societies like ASM and IDSA, the Infectious Disease Society of America, have directly been working to lobby Congress or with the White House task force to be able to inform them about needs on the ground. So for example, they've been able to advocate for increased funding in the stimulus packages to be able to go towards basic science research laboratories that are working on developing a vaccine. So I think scientists have been able to inform where funding needs to be directed, but Robert just mentioned especially that there's a lot of uninsured people. There's 30 million uninsured people in the US, and individual states, I know we talked about this yesterday, individual states do have policies also in place to be able to cover for the uninsured. Texas is a little bit different. For example, Massachusetts, they're able to provide resources and vaccines potentially, if one was available, would be able to be accessible. But for the states that don't have those policies in place, again, it's going to have to be part of the next stimulus act, kind of like how funding was redirected to labs in this particular Healthcare Enhancement Act.
So I would add something to it. I mean, we can have a vaccine, but we do have an anti-vaxxer movement ongoing. So, that's the other part, key on communication. Interestingly, I mean, it is a cost. I mean, even remdesivir, how much is Gilead gonna charge for it and how much that's gonna be available? I mean, there are states that won't be able to afford it, and then you have to think globally. The Gilead trial, for example, in Africa and Latin America, they can only access it through the World Health Organization Solidarity trial, and some places won't be able to. So whatever treatment comes is not just for the US and our health disproportionate communities, but also our middle and low income countries where we have the highest population, and they are actually the most people who are more vulnerable because they don't have access to care. And I mean, don't forget that the South has a big issue with access to care. Alabama, Louisiana, Georgia, Texas, and Florida have that, and Mississippi. And so how are you going to make sure that they get vaccinated if we have the vaccine? And how are the anti-vaxxers going to be an issue in that respect?
Also, really quick, I just remembered that another thing that a lot of states are working on is to try to do door-to-door outreach, especially when we're talking about rural areas that are very isolated, very far away from being able to receive any kind of care. This doesn't need to be just about funding, but we need to be in there in these communities, being able to inform people and be able to actually physically get things to them, especially if they're not able to access information easily.
Yeah, so touching on that really quick, my husband actually is an epidemiologist, and a lot of those types of outreach programs thankfully are taking place and have been taking place before COVID, but especially in response to that. One cool thing that he has taken part of, and that's popping up in other areas, is the use of hotlines. So yes, there are door-to-door interactions out in those communities, but then that brings up, what if the person isn't home exactly when the epidemiologist or other community worker comes by? What if that person doesn't want to speak with anyone face-to-face for various reasons? Or now are we putting our community workers at risk just by getting them into a closer proximity with someone who may or may not be affected, or just the different ramifications of that? So I think that these hotlines have been really awesome.
Definitely. It sounds like we have more of that looking forward into the future. So this is another very tough question. How should the public view the discordance between policies and scientific advice that is currently circulating throughout the world? Is this, like Robert said, just a feature of science that there's always going to be different perspectives? What would be your guidance to the public that says, like, I hear one scientist say this, I hear another scientist say this, I thought science is science, you know?
I think that there is a little bit of discrepancy, and it depends where your sources are coming from. So I think you have to first vet your resources. For example, having social media and WhatsApp has become a way of a lot of people, as well as the YouTube, to do that. And we saw an example of that with 2 emergency physicians who were not giving the correct information. We are all becoming experts because, as you said, we've been 5 months and we're learning, but I think you have to vet where your information is coming from. You have to have reliable sources. I think I speak for all of us. We try to follow our IDSA Society, ASM, NIH guidelines, and try to be there. One example, for example, was the use of vitamin C, zinc, and hydroxychloroquine. And there was 2 camps, you know, the pros and the ones who wanted to use or not. But if you look at the scientific data, which Robert and I had discussions, and even among our ID groups, that the scientific data was not there. But people were pressured into finding a cure because we want to do the best. But as physicians, our first job is do no harm. So trying to treat unnecessarily just to feel good about it might not be the best. So I think vet your resources, make sure they're reliable resources, and it's not something that just got passed down through the Facebook, Instagram, or WhatsApp.
I mean, there can be honest differences of opinion in science, just as there are in other areas of life. People look at a set of information, a set of data, and can have different interpretations of what the data means. And that makes it, I mean, it's difficult enough for us as scientists to figure out what's right and what's not. And it can only be more difficult for people not trained in the field. So my recommendation would be, much like Lila suggested, is that you pick your subject matter expert that you're going to believe. And a lot of people for this have picked Dr. Fauci. And everything I've heard him say, although sometimes he has to pussyfoot around certain issues, he still has not spoken misinformation. He's been straight on, accurate. And so you need to, if you turn on to different stations, the right, the left, you can figure out what stations those are, and are you hearing different kinds of interpretation of the same information, then you can recognize that there may be non-scientific issues playing into it, and then you have to seek out who it is that you have confidence in to help you interpret what's out there.
And I want to offer two important resources that I think have been useful for me. Both Layla and Robert mentioned this, but we normally interpret data given the expertise that we have, but there's also mechanisms for us to build consensus. Layla mentioned the IDSA, the Infectious Society of America, has guidelines. So that comes together by putting together a panel of people that will need to come to a consensus on how they interpret data. And the same thing for ASM, the American Society of Microbiology. They recently released a registry of vetted articles and both review articles and research articles that are reliable. And again, that was a way to build consensus on what we think is reliable information. And the public can actually access that. If you look up the ASM COVID-19 registry, you can look up a list of resources by field. So if you're looking for the clinical picture, epidemiology, diagnostics. So I think that is very useful. And in general, it helps for people to understand that not everyone in the medical field and science is an expert on everything in the medical field and science, right? That there's infectious disease doctors that know how to treat patients. There's clinical microbiologists that focus on diagnostics. There's epidemiologists that understand how transmission works and diseases spread. There's also basic science virologists that really understand viruses at the molecular level. So the fact that these two urgent care doctors, like Lila said, decided to do a testing study in-house to be able to extrapolate prevalence, you probably don't want me to be doing a difficult patient intubation in the ER. The same way, I don't think that certain experts are able to provide expertise on everything. So I think it's important for us to raise awareness about the different types of experts that are out there and understand that we know different aspects of COVID. We all don't know everything, and there's no way to do that.
Well, that was a great finishing sentence. I couldn't agree more. We're all specialists, and by that nature, it means we know a lot less about what we don't know than what we think we do know, or so forth. Okay, this is a great question that was asked by the audience, and again, it's definitely a panel-wide question. Modern medicine is built on the shoulders of historical medicine, and in the closet of historical medicine, we have skeletons where we've made mistakes. And those mistakes have led to some fear and mistrust when it comes to modern medicine. The question is, as we go forward and we want to start giving such a treatment, how do we, I'm going to use the word package, or make people understand that might have hesitancies to trust modern medicine, that, hey, this is real. This is the truth. We're not trying to hurt you, even though historically there's been some mistakes in the past of medicine.
I guess I'll start, and I know everyone can pitch in on this, but that's a valid issue. And I specifically think that they're referring to, for example, unethical experimentation and trials run on the Black community and things like that. And that's valid. That's all very valid. But I think in general, the medical and science community has a concerted push towards building diversity and moving towards, and again, I think our panel today here represents that quite well. And that's something that we're doing for ourselves. We're trying to make sure that we are understanding nuances in intersectionality and issues that different minority communities and marginalized communities face, and bringing that into the guidelines that we give. Our panels that we're building consensus on, not just guidelines for treatment, but guidelines for how to do research, interpret data, those are all diverse panels. So I think that's one way that people can feel a little better, that we're doing a lot better because we have a better understanding of the problems that were created to begin with.
And I think another important piece is outreach, and the outreach for one community may be different from that for another community. And so having having these outreach programs that are specific to the issues identified in a specific community, that educate them, inform them, engage them, is really important. And we're learning better how to do that across the nation, but we still have a long way to go. And a lot of times these outreach programs are underfunded, like a lot of things are, and we just have to try and do a better job of engaging the various communities that are being targeted.
I do want to jump in on that as well, as Robert was saying, that different communities are going to have different needs. I think that a job that doesn't get a lot of recognition is medical interpreters. So this field of healthcare professionals is wonderful. It's not easy for someone who speaks another language to put their care wholeheartedly into the hands of a doctor that they can't one-on-one communicate with. I think that expanding on that, not only are our medical interpreters really perhaps needed more than ever right now, just people who are able to help translate good scientific articles or even new facts and findings that they've heard to their families who may not speak the language that article was distributed in, I think are really valid, because as we all know, this virus is affecting the entire world.
Wow. I'm going to add one because I don't think either of you guys was saying it would have been appropriate, so I'll add it for you. Definitely throughout this discussion today, we've seen multiple examples where the correct answer was there is no correct answer, and that we don't quite know yet, and we're still trying to figure this out, and there's a long way for us to go. I think that sort of humility in the scientific community and the medical community is what also gets us to having populations that trust us again. So really well done today. I think we're just past our time, but I'm going to give each one of you a chance to say whatever it is that you want. No questions asked. If there's anything that you want to have be your last statement, and then we'll go to closing statements by myself, and then I think we'll wrap up for today. But thank you very much for joining. Anybody can start, by the way, sorry.
All right, I'll start. So I want to first thank you for the opportunity for participating in this. And I want the public to understand that certainly what we've been able to do here locally in Houston and in different parts of the country has been to flatten the curve. And what flattening the curve means is that we are not, by flattening the curve, we're not necessarily meaning that in the end, a smaller number of people are going to become infected. We're just allowing our healthcare system to better be able to handle the load of patients that come in to be cared for. And it also gives us time to develop treatment strategies such as the remdesivir success that was reported in the last week that may not only shorten the course of her hospitalization, but decrease mortality. And then it also gives us time to develop a vaccine. And so while people may look at a second or even a third wave as a sign of failure, I don't think it is. We have been successful in delaying and being able to manage the patients so far that have come in, and We have had time now to develop strategies for managing these patients better, and for improving health outcomes. So thank you.
So thanks for the opportunity to the Texas ASM chapter and Aisha for inviting me over to talk about a little bit of our clinical experience. You know, we've learned a lot. We live in interesting times. I think we'll probably see, you know, what we know today will be very different from a year or 2 years from now. And even probably will be judged 50 years from now as not handling well or not well the things. But one of the things is to continue doing what we're doing that has helped us flatten the curve, as Robert said. You know, the social distancing, the masking, the washing your hands, cleaning the surfaces. I think that's what the new normal is. And have patience as we reopen. You know, that's the only way not to have the peak of the cases and be like New York or Italy or Spain. That's the way. And then the other thing is that I always thank everybody who makes my life easier, from the microbiology lab techs to the EVS to the pharmacists to our APPs and our respiratories and our nurses and our units, because without them, we could not do our job. So thank you.
I guess I'll go next. This is a hard time for everyone. And I want to say honestly that my heart goes out to everyone affected by this pandemic that we've never seen before in our lifetimes. To the scale. Anyone who's lost a loved one, people working on the front lines, especially people working on the front lines, the fact that you've had to risk yourself and your families. But I want the public, I guess, to know that we as the scientific medical community are not just finding a way to come out of this and end COVID, but we are fighting and advocating for ways that we can create long-term change, because you deserve better. People that have lost their jobs, you shouldn't have to choose between feeding your family or following CDC public health guidelines to stay home. Our vulnerable communities, people of color, homeless individuals who are at the highest risk, the uninsured. We need to be able to protect you for when this happens again. And we also as a nation need to be able to respond and act early. So I think I want y'all to know that we will continue to push past this, and we will find a way to build together. I also want to give a shout out to my team at ASM for being incredible through this entire period. My content creators, my officers, everyone in Texas Medical Center, ASM chapter, thank you so much for believing in the power of public outreach and putting this webinar together, because this was a huge team effort, and of course for Taste of Science as well.
Okay, this is a super tough act to follow. Everyone gave such great sign-offs. Obviously, I want to echo everything that the three of you guys have said. First and foremost, thanking you guys for asking me to be a part of this webinar. This is wonderful. It's very encouraging as a recent grad myself to see people taking up the torch, especially in such a crazy time. I hope that the public knows that us in the healthcare community are doing everything we can, even if you don't see us beyond situations like this. Please know that we are working day and night to try and find solutions, not only to new treatments, but also, as Aisha was just saying, policy changes moving forward. I think that exciting is an interesting word. I think that normally we think of that as a good thing, but exciting, you know, can also just be something new, whether it's positive or negative. I think this is an exciting time. I think while we're dealing with a lot of negatives right now, from those negatives, a lot of positives will hopefully come, as cliche as that may sound. I really hope that members of the public, and those of us too that are scientists, continue to remain positive, continue to remain creative in the different types of outreach and communication, and even entertainment that we've developed in such a short amount of time to deal with this. And I just hope all of that will continue.
That was wonderful. Thank you so much. So we're going to shift to the final words of the event. One more time, though, I want to really call out the organizations that helped put on this event: Taste of Science Houston, one of our sponsors, the Association for Women in Science, this association, I keep messing this up, I'm sorry, Aisha, ASM-TMC, and their Young Biologist program, where they raise funds to help support outreach, the same outreach that we just described, into the general community. And with that, I'm going to shift to our last words. Okay, so that was a fantastically informative event, and a big thanks to our speakers, our sponsors, and the entire team that you can't see right now that are working behind the scenes. But another big thank you goes to you, the audience, because you took the time today to come here and listen to the experts. You didn't settle for what the CNN or what Fox told you. You didn't settle for the government press releases. You decided that it was best to hear it from the scientists. Now that's the first step in building an informed, scientifically literate world. It's why we put these events on. And so thank you for coming. For all of those that were directly affected by COVID-19, our thoughts and our hearts go out to you, and may we remember your pain as we design the programs and the regulations and the tests for future pandemics. If you liked what you heard today, please come check out a Taste of Science Houston or your local Taste of Science events. You can find them on Facebook. If you want to get informed on the go, check out the podcast Microcast, put on by ASM. It takes the complicated and makes it uncomplicated in the world of infectious diseases and microbiology. Finally, don't forget to send us feedback about this event. What did you like and what did you feel was missing? What would you have liked to see? Would you like to see more of these events? We hope so. And with that, have a great day wherever you are. And thank you for coming together with us on this. Bye.